Welcome to the Dr. April Jasper Show, relevant conversations for business owners of today. I want to change gears a little bit because what Dr. Liu has done in the clinic here is she has established some really amazing protocols, and we won't necessarily go through all of that and what you do with a myopic patient when they come in. But let's talk about some of the things that we should be thinking about in our offices. So now you have a patient that was referred by another patient. They come in. Let's take a 6-year-old who is a -2 as an example. What is the first thing you're going to do in the clinic? And then how are you going to manage that process for the next upcoming years?
So we're mostly talking about the most important things we want to communicate with parents, almost like as the first time they're coming in for a consultation. Yeah, so there are objective and subjective factors we really need to discuss, but obviously to make this conversation as custom tailored, we would need to do a very comprehensive pretest to establish a good baseline. By good baseline, we need to understand how the kid is using his or her eyes, and what's for a lot of near activity, what is the relative composition between reading physical books and playing Legos or other toys versus computer games and doing a lot of social networking on iPads or cell phones. And to get a very detailed case history, ocular history, as well as like a systemic history of other possible conditions causing myopia, for example, Marfan's, Stickler's, or Usher's, whether this is syndromic myopia or this is a standalone problem. Objectively, by getting a good baseline, where we need to have a good autorefraction, and I know most doctors are saying, autorefraction cannot replace subjective refraction, but it's something that we know is the standard of measuring refraction from all of the clinical studies. So if we want to compare to what we have learned from clinical studies, we need to do it the same way. So autorefraction, preferably cyclopleged. Without cycloplegia, it's still better than not having an autorefraction. And optical biometer reading, specifically getting information of the axial length and all of the components that contributes to the overall axial length, as well as a baseline corneal topography to see whether the kid is a good candidate for any of the contact lens treatments. From there, we can deliver a very custom-tailored conversations talking about the pros and cons of all of the available evidence-based options, their time, parents' time and financial investment, as well as whether each treatment fits the best with the patient's lifestyle. We know if this is a treatment that kids cannot be compliant with, it's not going to be a good treatment.
So two of the things that doctors tell me all the time that they struggle with, so I poll them at meetings that I go to where I'm speaking, and I have an audience response system, and I say, what are your biggest challenges? What are your roadblocks in myopia control? And they say cost and the conversation with the parents. So how do you suggest they get through those challenges?
Let's start with the conversations. I have mentioned the earlier the intervention, the better the cumulative outcome. So to get the intervention initiated early, we need to have the conversation started even earlier. And by the time the kid is already a -3, that's already a little bit too late in terms of starting the conversation. So I would encourage everybody to start the conversation anytime we see an adult, a parent patient, when they're showing any signs of retinal changes. The next conversation should be, do you have children? If you do, when was the last time you brought them in for an exam? And let us evaluate the risk. If they haven't developed myopia, what's their risk? And if they are already myopia, what's their options? And the second would be, for all of the patients coming to get myopia control treatments, I naturally ask parents, do they have younger siblings? And so that we're not talking about, providing treatment to this older child, but also what we can do to your younger child. And the third is to talk to those parents who started like only thinking or asking questions about myopia management, we should really bring their children in for a good baseline. Even though it's a 4-year-old plus one, that's still a very good, important baseline for us to understand what is the axial elongation just as a function of a body getting taller. Without knowing that, we don't actually know how much of the axial length elongation that's related to the progression of myopia.
So then how about cost? How do we deal with that?
Yes, so cost certainly is a big consideration. At this point, I don't think we're able to target every patient who's indicated for myopia interventions. So I personally feel like our priority should be those who are ready, motivated, and financially capable.
That's good.
And currently, I see this mismatch of the industry partners really trying to improve the disease awareness of myopia, but at the same time, doctors are not really driving their effort in focusing on those who are desperately looking for doctors to start their children in myopia interventions. Yep. And so instead of converting someone who's not motivated, who's not psychologically ready, we should really try to find those patients who are ready but having difficulty finding a good doctor to work with them.
How do we do that? I love that. I think it's good advice. And I think the one benefit, as we all know, that Dr. Liu might have here is by the time they come into the clinic, they're ready. Mm-hmm. They're probably, your conversion rate from patient coming in to actually moving into some interventional treatment is probably very high.
Yeah. So I see this very interesting disconnect. I've heard a lot of doctors in saying, oh, I really want to start doing myopia management, but I'm having difficulty finding patients. But I also manage a very large group of parents, roughly about 1,500 parents. And we have this WeChat group that we constantly educate new treatment, new publications, and other things. The number one question parent ask in that group is, where can I find a doctor who can see my child?
Wow.
So you can see we have a lot of parents looking for doctors. We have a lot of doctors looking for patients. We just don't know how to match them together. We may need to find a website, it's like a match.com.
Right.
That, I think, with the help from our industry partners, we're able to match the resources better with the demand.
I love it. Yeah. That'll be great. So you mentioned biometry. So first, let's talk about what people, they hear us say A-scan and they hear biometry, two different terms. Talk about why two different terms, and then do you have to have that to do myopia management?
So biometry, I think A-scan is a part of biometry. It's just not an optical biometry. And optical biometry is using laser sources instead of ultrasonic sources. So the resolution is much better, and it's in general non-contact. So it's much more suitable to start younger kids without causing too much discomfort. But I don't think you need to have an optical biometer, which is a lot more expensive than an A-scan biometer. I know there are several options of a high-frequency A-scan biometers. They're able to give us a resolution of about 0.05 to 0.1 millimeter detectable difference, which is still much, much better than not measuring kids' axial growth. Now, coming back to this very commonly debated question, do we need to measure kids' axial length? My short answer is yes. I think if we're doing a lot of ortho-K for adults for the purpose of myopia correction, I'm just, using these resources to fit some sporadic kid patients. That's probably okay. But once we started claiming ourselves to be the myopia management specialists, especially the majority of the tool as a ortho-K, without knowing the exact refractive state of the children, the only way we monitor them for any subtle changes is by looking at the difference of their axial length. So yes, once we have charged the patients at the level as a myopia management specialist, I do believe we need to invest in an optical or A-scan biometer. It's almost like you claim yourself as a glaucoma specialist but not doing OCT.
Right.
Do you need to be a glaucoma specialist to manage glaucoma patients? No, you can still prescribe drops for them. But once you claim yourself as a specialist in doing that, not doing OCT for glaucoma management, treatment is almost considered as not doing axial length for myopia management.
I love that. I've never heard it presented that way. So great job. And that makes a lot of sense to me. So let's talk about prevention. Now you have a patient that comes in. So it's the 4-year-old who came in because brothers and sisters are all myopic. The 4-year-old is emmetropic. So what are you going to do with that patient?
So there are certainly behavioral modifications. We really need to encourage this 4-year-old to stay outdoor as much as possible. And by as much as possible, I'm not talking about a prolonged session of outdoor break. I'm more talking about very frequent outdoor breaks. And most people interpret outdoor breaks and its protective effect against myopia as a cumulative dosage. This is actually not true. So spending 2 hours outdoor in one single session is not going to be as effective as doing like a 10, 20 minute sessions.
Okay,
and
good.
The more it's delivered right after the near work, the more effective it is able to cancel out the myopia go signals.
Wow. No, I haven't heard that either. So that you taught me something else today. All right. So I asked Maria this before we started recording. I said, I've been in Arizona, I've been in Alaska talking about this. And doctors say to me, but what am I going to tell my parents about their kids and being outdoors when it's cold outside and it's dark, or in Arizona when it's hot outside? How do we manage that?
So there are several important things I want to mention related to your comment. Number one, we've heard about this 20-20-20 rule, and this outdoor break kids use to really maximize its benefit in myopia protection cannot be too short. So 20 seconds of a visual break is not sufficient enough to make the eyes realize, oh, I'm in the need for a break. And for this 20 seconds of a distance viewing, it's usually not capable to elicit any of the choroidal mechanism and to actually cancel out the harmful go signals. So in order to work as a good like a relaxation or a break to minimize the risk of myopia development, it needs to be in the scale of 3 to 5 minutes minimally. Now, when you're actually taking a very long outdoor break and you have a saturated effect. So going back to your question, Arizona, Alaska, and it's more effective to make the breaks shorter, and anywhere in the range of 3 to 5 minutes, the shortest, but probably 10 minutes is doable. And to do more of that rather than just staying outdoor for a very sustained amount of time.
So indoor at the gymnasium isn't as good as outdoor.
The evidence on that is unclear, but we do understand is the outdoor lighting has a very distinctive like a difference compared to indoor lighting, both in terms of intensity as well as the spectrum distribution. So even for a very cloudy day, even a raining day outside, it's still log scales more brighter than indoor lighting. So far we haven't had any evidence showing the like from ecological studies showing the areas tend to have a lot more cloudy days or rainy days. The outdoor break does not seem to be as effective. So from that, we know that outdoor break and the very, very distance viewing across the whole visual field is much more effective than a very large conference room or gymnastics happening indoor.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
So I interrupted you, and I apologize, when we were talking about preventative measures. We talked about outdoor time. What about sleep?
Yes, so another thing that can disrupt the overall eye growth, or especially the eye growth related to the body's physiological development, is related to the disruption of sleep patterns. And so there are some animal studies showing when the animals are reared in a very disruptive sleep patterns, where on and light on versus light off cycle, their amyotropization process can be affected quite significantly. So axial length is a complicated picture that has both a physiological component related to the normal body becoming taller. Another layer on top of that is abnormal visual experience induce abnormal axial elongation. So at this point, we're not seeing like for keeping kids awake would actually be protective, but from the normal development sake, having good sleep patterns would be protective to at least a physiological component of axial elongation.
So is there an amount of sleep every night or a time you should be in bed by?
I don't think we have enough studies of showing, that evidence. But another thing I want to emphasize, we only have 24 hours a day. So the less time you put in sleep, the more time, very likely they're actually doing a lot of neural work. Yeah. So research, it's hard to tease out whether it's because of the lack of sleep or it's just increasing hours of a neural work.
So you brought it up again. You've mentioned it a couple of times, digital devices. Tell us what role they play in all of this.
Again, the evidence is not super clear. Number one, because the quantification of a digital device using has not been very ideal.
Right.
Mostly we're using a subjective questionnaire, and sometimes it's the questionnaire from parents. And if I ask any of you to estimate how much you have spent on your cell phone versus what your cell phone is telling you how much you have spent on it, we know it's a very poor correlation. So one problem with the evidence on that is we haven't figured out a good way of objectively quantifying how much time kids spend on their phones.
Right.
And the second problem is very similar to what we have discussed on the outdoor break, is that the time spent on digital devices is not linearly accumulative. So a 2 hour of nonstop use on the cell phone would do a lot more harm than using the same amount of cumulative time, but chopping them down into shorter sessions and interleave with a good break. So using a cumulative time of screen is not a sensitive way of understanding its risks. And then third point I want to emphasize is the working distance. In general, electronic devices tend to be associated with a much closer working distance. And we know this dioptic stress. So for the same amount of reading, if it's happening at a 40-meter arm length versus a 10-meter cell phone, its impact on myopia development is dramatically different. So simply measuring the accumulative time of a digital device use without looking at how the pattern of its use and without objectively quantifying it, I don't think we're quite there yet in understanding exactly how much risk is inducing, both in terms of early onset as well as progression.
So I know that we have talked a lot about these things, but Maria, you're just such a wealth of knowledge. I just need to know. I know people ask me this all the time. How do you decide, patients here, it's time for treatment, which of the options that are out there, without naming names, because, well, or you could. This is a podcast. It's open for a discussion. But how do you decide which treatment is best for which patient?
Currently, unfortunately, in terms of the number one factor parents look at is the efficacy. Unfortunately, I haven't read anything that clearly shows one treatment works better than the other treatment, even among the same modality, let's say ortho-K. Despite some manufacturers saying we have some myopia control optimized design, I don't think we're quite there yet. And so I would not, between multifocal daytime soft lens versus overnight ortho-K, certainly the decision to me is not based on the efficacy. It's more on the parents' predisposition of the safety of the treatment, how feasible it is to match the lifestyle of this kid. And so this is certainly a very multifactorial decision. And to me, I'm biased toward the optical treatments more so than the atropine, because atropine, it's only limited to its myopia controlling effect without a correcting effect. So it still need to be combined with an optical correction, versus for both the daytime multifocal lenses versus nighttime ortho-K, it's almost like a one stone, two birds situation.
Right.
And between the two, daytime soft lens versus nighttime ortho-K, I'm biased toward ortho-K. If I'm seeing a younger patient, a lower myopia, parents can actually take over the lens cleaning and insertion removal, and versus older patients who are more independent in contact lens handling. And sometimes outside of the range, I feel very confident to have the best safety and a long-term consistency in ortho-K. I'm biased toward daytime soft lenses.
So here's a big question for you. If you were me in private practice, how would you address this world of myopia? What would you say to a doctor who's listening? Because we have people that are in practice for 25 years. We have students that are just getting out and starting their practice. How should they be thinking about myopia control, myopia management? What would you tell them today?
So the number one message I want to send out is that myopia management in the future is going to become the standard of care. Whether you choose to ignore it or not, nowadays, it's something that patients and parents will come ask us. So it's better to keep ourselves informed and up to date in terms of what are the options available out there. And number two, early intervention is the key.
Yeah.
No matter what we do, the earlier we start it, the better the outcome. And number three, there are going to be more and more modalities available, especially now we hear really promising data from novel spectacles. And so for those doctors who are a little bit uncomfortable fitting kids in soft lenses, we will have some really exciting options for you that doesn't require specialty contact lens training, but we can still do better than simply prescribing single vision glasses.
And I know that, well, I've asked you a lot of questions, so let's ask this one first. Is there anything we left out, anything else that you think that people need to hear, questions that you get maybe that I didn't even bring up?
No, I think we've done a really good job covering the most exciting topics.
All right, so then my final question, everyone wants to know what's next for Dr. Liu.
So I have a very exciting project. I'm starting a new myopia control clinic as a private clinic outside of Berkeley.
Yay.
Yeah.
That's going to be so fun. And it'll be soon, right?
I'm hoping so. Yeah.
Okay.
I'm hoping the clinic will start getting ready for patients in late October.
Oh, congratulations.
Thank you. Yeah, currently I have a lot of patients traveling in an average radius of 30, 40 miles, and many of them are coming from the area where I know I can have, I can serve them better. Yeah.
And you know, I totally forgot to tell everybody that one of the things that you teach about is also that the comparative studies, see if I got this right, Maria, on the similarity and difference of primary vision care in developed versus developing countries. So you know more about that than anybody probably that I know. What would you say about that? And what should we be grateful for, I guess, in our country? But how is it different in other countries? Are we behind in some ways, ahead of other countries? Where are we at, and what can we do better?
It's very interesting. So in terms of primary vision care, we're definitely ahead of the most of the developing countries. Taking mainland China as an example, there is no such thing as primary vision care because all of the vision care is cash pay. And there is no insurance cover general eye exams, so it relies on much better disease awareness from parents to bring their kids in for early baseline, especially like establishing the optical ocular growth profiles. Yeah, and so from that, our insurance system it's so comprehensive. The majority of the comprehensive eye exam can be covered, and so that's really giving us no excuse of not detecting myopia earlier.
Yep.
Even that myopia as a disease has much better awareness in China. It has been recognized as a disease like hundreds of years ago.
Wow.
So when you have a Chinese family coming in, talking about during the consultation, it's not so much about convincing them to engage in a treatment. It's just a matter of what treatments to consider and why. And versus when I talk about a non-Asian family, I still need to spend a lot of time educating them why myopia needs to be controlled.
Right.
Yeah. So a lot of conversations on the risk of retinal complications, et cetera, et cetera. And let me just give you a very funny example as the ending of this conversation. I have this turning 5-year-old boy, not speaking much English. During the consultation, I did the auto refraction on this kid. This kid replied to me in Chinese in saying, "How much is my hyperopic buffer?"
Oh my goodness. That's incredible. Were you shocked, or is this something that happens?
I've had similar experience before, but not from a 4-year-old.
Oh my goodness.
But I just want to remind you, myopia management has a huge cultural difference.
Yes.
Some parents are coming in really, really prepared. Another extreme example I had was a parent asking me how much of the spherical aberration you're inducing from the Ortho-K treatment to my child.
Oh, man. I'm not even sure what I would say. So I'm glad they're seeing you, Maria.
Yeah, so huge cultural difference in terms of what they perceive as the first choice for their kid for myopia interventions. Yeah.
Well, I think everybody knows this, but I want to say it again. I have been passionate about myopia since the day I realized what myopia was. I remember as a little girl looking for my dad's RGP contact lenses on the ground when one would pop out of his eye, and then as a young optometrist saying, I hope one day I can do something to prevent this. So I'm all about this, and I just want you to know, as our final, conversation piece, how much I appreciate, and I know everyone listening appreciates the research you're doing, the information you bring to us, and providing us with the ability to change our patients' lives. So thank you so much, Maria.
Thank you. Thanks for inviting me to this very, very exciting podcast series.
Thank you. Mm-hmm.
If you suffer from dry, scratchy, irritated eyes, the problem may actually stem from your eyelids. Cleansing eyelids daily is essential for maintaining healthy eyes, which is why doctors recommend OcuSoft Lid Scrub Allergy Eyelid Cleanser. New OcuSoft Lid Scrub Allergy removes oil, pollen, and other contaminants from your eyelids to effectively reduce redness, irritation, and itching caused by seasonal allergies. These pre-moistened wipes are easy to use, on the go or at home. Simply wipe and leave on. As the industry standard of care, OcuSoft has a full line of eyelid cleansers for various conditions. Available through eye care professionals, most retail outlets, and Amazon.com. Visit OcuSoft.com for more details.